seen both of us here before. I recognize a lot of the same faces. Just like last time, if you guys have anything to eat and drink, by all means take it out. We're not trying to disrupt your guys' lunch. We do appreciate you being here and taking part of this pilot case study with the U.S. Army and NOVA. Before we get started, feel like it might have been you. Were you the one in the red back there last time?
No.
Oh, okay. Is he here? The guy in the red sweatshirt? Oh, you? No. Okay, I'm just trying to find the guy in the red sweatshirt that took like the video of the guy taking the NPA. I just wanted, if he was here, you guys could, if he could give us that video. But okay, we'll move on. So, okay, just felt like I should take that opportunity. So today we're going to talk about respirations and respiratory management. So if you guys have been part of the classes before or seen the video, we've covered control the bleed and airway management. So there's a specific reason why we're going in this order. I don't know if Sergeant Duran discussed that the first day, but we have something in the Army we call HABC. It's an easy acronym to remember when you're treating life-threatening patients or life-threatening injuries with your patients. So H stands for hemorrhage, like massive hemorrhaging control. That's when you're using the tourniquet, the combat gauze, and all of that you guys did the first time. Then A is for airway, like we did last time. You're inserting the NPA, the King LT, and then doing the Crike. And now today we're hitting B, which is breathing, and how to treat for injuries related to the chest area. And then your C, it goes down to the circulation, which we're not going to go over in depth with this case study because we can't do a lot of the treatment that we would normally with you guys, which is like IVs and ensuring like the adequate blood flow and everything is occurring within the body. That being said, we'll move on. So our classes, again, penetrating chest trauma and decompressing a tension pneumothorax. Next slide. Did you put one? Oh, okay. So after bleeding, the second leading cause of death in the battlefield is chest trauma, usually penetrating gunshot wounds or penetrating wounds from like an IED blast, so an improvised explosion device, or bomb detonating and then debris flying and puncture somebody in the chest or in the lung. So you guys are all pre-med or biology majors, so I'm not going to insult your intelligence too much. So you guys probably know far more than I do. You guys have taken A&P 1 and 2, I'm assuming. I did, but online I got C's. So, so you know you have 2 lungs. There's 3 lobes on your right and 2 on your left because the heart takes up some of that some of that space. So move on. I'm not going to read the slides for you. So this is your lungs, if you guys didn't know. It's inside your body. Move on. So I apologize in advance. So again, some of you guys I talked to last week. So I am a medic in the Army, but I've been so far removed from that line of work. So some of this is me learning with you. No, but I'm not the best teacher at it. Sorry, we wish Sergeant Duran was here. But we will send you this slide deck, and again, I know I owe you guys the slide decks from the last 2 times and the YouTube videos. Just been like busy being gone for a month and a half, like trying to play catch up. So by the end of the week, I promise. So, okay, come on. So when an object penetrates the chest wall, it's called a chest wound. It can be caused by a bullet, knife, sharp objects. Like I said, a bomb. So, you know, Miami is kind of like a rough spot sometimes. So gunshots and stabbings kind of are a little more prevalent than Bowling Green, Ohio, where I'm from. So this information you guys can take back with you and maybe save somebody's life. So the biggest concern here is when you have a penetrating wound is that it punctures the lung and then the lung collapses. So that's what we're going to focus on today with your interventions. Okay, go on. You can jump in anytime too and save me from this. Okay. So sucking and hissing rounds coming from the chest wound is what you'll most likely hear. And then obviously there's other signs that you might see. So normally you have a bilateral rise and fall of the chest. You're going to see a unilateral rise when somebody's been punctured or their chest has been punctured. You're going to start seeing cyanosis, so blue around the lips, real bad like fingertips because they're not getting adequate airflow. So another term for this is called a sucking chest wound because of that sucking sound, that hissing sound that's being created. I see you guys taking notes. We'll send this to you so you don't have to if you don't want, but go on. So it must be at least 2/3 of the diameter of the trachea, thank you. So that's what's gonna make the sucking sound. Coughing up blood is gonna be another sign. There is an intervention where you can do like a chest tube as well, and that drains the blood, but that's a little more above my medical expertise, so we won't go over that. And then you might see like blood or frothy or bubbling sensations coming from that penetrating wound or that hole that's in the chest, because it's just trying to like get out of the body. Okay, go on. I mean, I feel like this is, like, we kind of already covered it, like shortness of breath, difficulty breathing. It's going to be very painful. It's going to feel like somebody's like somebody's sitting down on the chest. They're not able to have normal inhalation and exhalation of breath. Pain in the shoulder or chest area. We already talked about like the blue around the lips and the fingers. Rapid and weak heartbeat. So you can check a person's heartbeat as well. That's another like way to be able to like determine if they're having difficulties. Okay, so if you don't know if it's if it's like a situation where you do need to do treatment, just do it in case, because it's not going to further injure them. It's only going to help the situation. Go on. If I'm talking too fast, because I do tend to do that, let me know. But I'm trying to go through these so you guys can do more hands-on, because I like hands-on stuff better. So you're going to want to seal the chest. So there's been, like, the Army keeps going back and forth on like how we seal the chest, the chest wound. So in the past it was like you tape around 3 sides of it and then like you leave a flutter valve. So last time I went through my medic training 2 summers ago, we were going to cover all 4 sides. So do you guys learn something else? Because I'm getting faces.
Well, I'm an EMT, so we're told to do the 3-sided.
So 3 sides. So when did you guys go through EMT? Because, like I said, it's been 2 years.
We went through my the clinical stuff this past summer. And
Okay.
I still passed with the 3-sided. They didn't tell us it had changed. So.
Okay.
I mean, it depends on like if there's an open exit room. So it depends on that too, because you might have to use occlusive instead.
That's what I brought, is occlusive dressings. So do you guys understand what we're talking about? So EMT and Army, so I'm EMT trained, but we go through our training every 2 years. So in 2018 was the last time I went through. They always are going back and forth to decide if they're gonna seal all 4 sides or tape down 3 sides and then like leave a flutter valve, or they even have some equipment where it actually has like a like an area for the air to escape, flutter valve. So the first thing you want to do when you come across a patient is, they teach you in EMT, is your scene safe, because you don't want to become a victim as well. So make sure that the scene's safe, don any protective gear. So I didn't bring gloves because we're just playing with the mannequin, but normally you're going to put on gloves. And then H first, what's H? Hemorrhaging, because a person can bleed out faster than not having oxygen, right? So covered our H, we're good. We're gonna go to airway, so you're gonna do your head tilt, chin lift, look, listen, and feel, and then Once you've taken care of that, you're going on respirations. So you can do these steps simultaneously. So you're gonna look, listen, and feel when you're doing your airway. So you're gonna look, listen, and feel while you're doing your respirations as well. So you're making sure like you have bilateral rise and fall of the breath. It's adequate. It's going like the depth it needs to. EMTs, how much is the depth supposed to be?
2 inches.
2 inches? Okay, good. See,
I think.
you know more than I do. Did you guys learn this at EMT? I feel like you didn't, or did you?
They never
Yeah.
really specified, for me, they never really specified how deep it just needs to go. It just needs to show that it's decreasing significantly and increasing significantly just for, because you're not going to be able to measure out to
Right.
It
Of
depends on
course.
the case. They say about 2, but like you don't really know. Like when we do our testing, our dummies have lights on them to show us that we're going deep enough. So.
Oh,
Yeah.
okay, fancy. So then make sure like the person is exposed. I forgot to mention that part, to see if you can find a penetrating wound at all. So that's what you're gonna do when you're listening and feeling. So you're checking all this at the same time. So you're gonna see if there's a gunshot wound or something penetrating the body, or there's like a hole in the chest. So the first thing you're gonna do is cover it so that air is trapped inside and it's not being released. Probably going off script at this point, I don't know. So these are expired, these are used, or not used, they're expired, but they were like with other stuff. So this is a hyphen, it's a chest seal. Do you guys have this at EMT?
No, I don't think so.
So this is a very, very adhesive, sticky piece, and what it does,
Are those in the IFACs or they don't come in the IFACs?
they are in the IFACs. So she asked the question if they're in the IFACs. IFAC is like a little personal medical kit that soldiers carry around with them, primarily in the battlefield. It has a tourniquet, it has a hyphen or chest seal, it has, we're gonna cover, everybody likes a needle chest decompression needle, and an NPA, and like some combat gauze and a couple other things. Trying to think what IFAC stands for. Individual field, individual first aid kit. Yeah, you're right. I don't know why I was saying field. So, you've covered up your hole. This thing comes with gauze, so you can wipe away the blood. But to me, I'm not even worried about that because this is gonna keep bubbling the longer it's open. And see, it has all 4 sides. Just slap it on there, and it's gonna stay. Some people put tape all around it to secure, but this thing is should stay. Then the next thing you're gonna do is turn your patient over to ensure that there is no exit wound anywhere in the body. In this case, there's not, thank God. But if there was, you know what you can do instead of opening up another hyphen chest seal, especially since the Army only has 1 on the person, you can take the wrapper and tape it on all 4 sides, and then you have 2 seals. So after your intervention works, then you want to continue to assess your patient and ensuring that they have bilateral rise and fall of the chest, they have adequate depth in breathing, they're getting adequate airflow. Majority of the time, this is not going to hold for long, and there's going to be pressure built into the chest, and it needs to be released. So, do you know what to do? EMTs?
I mean,
I gave you a hint earlier.
use that to
Yes.
reduce the air.
So you're gonna use the needle chest decompression. We can go to that slide because I forget all the data pertaining to this. So I think it's like a 3.5 or 3.25 inch needle.
It's very long.
Hmm?
It's very long.
Yeah. So these are the different styles that they've gone through different like iterations of it. This one has like the flutter valve, and that one does too. But this is the one the Army uses. Have you guys seen different ones in your EMT kits?
I've never had to use one, thankfully, but I'm pretty sure we just use flutter valve ones, because that's the way we were taught. I'm not sure if it's different for each county.
Well, I mean, EMTs, yes, should have the same standard across the country.
It's also budget.
Oh, no, not the kids itself, I meant the training.
Oh, yeah.
Keep going. So this is just going over everything I just talked about. Did you have any questions so far with what we discussed? Okay. Get very nervous being videotaped, by the way. No, we'll come back to this. We'll come back over a palette. So tension pneumothorax, that's where we're at right now. So that's what happens when you have the chest build up, or the pressure build up in the chest. You would start to get tension pneumothorax. So let's go over all the signs and symptoms for it, because I can't remember all of them. But you have trachea deviation. That's like one of your last stages, like where your trachea is like moving to one side or the other. If you see somebody like that, like you better help them now, or they're gonna expire. But see that? Oh. Go back to that one picture. Huh? Oh no.
Picture or?
Yeah, go. See, there's a pressure buildup and everything's getting pushed to one side. Go ahead. It's a real version of a tension pneumothorax. But so cyanosis is obviously a sign. Your lips, fingers turning blue. Trying to think of the other signs. Help me out.
I mean, you would notice immediately that there's
With the bilateral.
bilateral chest rise. That's what we look for immediately.
Here we go. So absent breath sounds.
Pulse would be also
right.
down.
Distension. That's what I was trying to remember. Like so, the veins in the neck. Like when you see somebody like a weightlifter stressing because they're holding their breath while they're lifting, like those big veins, that you're gonna see that as well. So keep going. So those are some of your signs and symptoms. See the veins, they don't have a trachea deviation picture. Keep going. So other signs of a tension pneumothorax but these can apply to a lot of different injuries, right? So low blood pressure, cool clammy skin, they might lose consciousness. Keep going. Trachea deviation, which I talked about, that's the last stage. Keep going. Keep going. Go to where you can find the NCD information. New chest decompression. Go to the next one. Okay, 14 gauge, 3 1/4 inch needle. So that is what you're gonna stick in the person's chest on the wounded side to release the pressure build up. So you're gonna go, you can move down to the next side while I'm explaining it. Okay, so perpendicular, midclavicular, between the second and third rib, above the third. Do you know why you go above the third rib and not below the second? Because there are, I'm trying to think the word it's called. You know what I'm talking about?
Ribs?
No, between the ribs in that second intercostal space, but you want to make sure you're above the third rib and not like putting this right below the second, because there's a lot of nerve endings right there. So it would be, even though your patient's probably already in pain, it's going to be extremely painful. So you want to keep that into consideration while you're doing it. Also, so that's your first, in the second intercostal space, between the second and third rib is where you want to put the NCD, but there's also a second place to put it if that one's not going to work, or if you put in a bunch and you need a second place to put it. So it's between your fourth and fifth on the side of your body. Again, above the rib, not below. So somebody told me this a long time ago, if you take your hand and you make like the, trying to do it. So if you make like the Hawaiian choker, and then you take your middle finger and you put that between their clavicle, where your middle finger lands should be approximately in the second intercostal space. Also, for the fourth and fifth and the fourth intercostal space, if you take the patient's arm and you reach it across their body, again, where their middle finger falls should be between the 4th and 5th rib. And then I'm even lucky because I have like a mole right here, and that's pretty much where my second intercostal space is. Now it is going to be difficult to find those ribs on heavier set people or women that have larger chests. So just keep that in mind while you're doing it. So again, you're looking and feeling, and you can feel the ribs on this person. So this is your clavicle, move down, your 2nd rib, and your 3rd rib, and you're just gonna go perpendicular, mid-clavicle, midline to the nipple, and you're just gonna insert it. You should feel pressure being released. You can hear it sometimes once you release the needle. You can be able to feel the air and the pressure being released. You're gonna tape it down. I think I brought tape in there. If not, you understand how to tape something. And eventually, like if as time goes on and help hasn't arrived for the patient to go to the next echelon of care, this will start getting clogged up with blood or other body fluids. So you are able, just in the same spot, like by the right and left side, continue to place NCDs. And then again, you can always place some. Somebody help me out with my anatomy right here. What?
Mid-axillary.
Mid-axillary. See? Okay. Mid-axillary, you can put them on this side too. This is also, the mid-axillary is also where you're gonna do your chest tube, but we're not gonna do that. So, go on. So you feel a pop sound. Like I said, like there is a lot of pressure, so you should definitely be able to feel it. The patient's definitely gonna feel it, and you should start seeing signs of improvement. Go on. This is just this demonstration of how to do it, or where it's placed. Go on. Go on. Go on. Oh, we went over positioning last week, those of you that are here. So this is usually the best way to lay your patient on the injured side down, where their head's tucked and you have one leg tucked underneath, or over top, sorry, to help if like they throw up, they lose consciousness. But really, at the end of the day, it's what's most convenient and most comfortable for your patient. A lot of times when people have difficulty breathing, they like to sit up. So just like when you have a cold, all that mucus and everything's falling down into your throat and settling in your lungs, that's why we like to sit up our patients. Go on. Oh, that's it. See, told you I was going to give you guys plenty of time for hands-on. Does anybody have any other questions or concerns at this time? Because this is stuff that you guys are going to do when we have our culminating event. So that's why I want to give you guys enough time to practice and answer ask individual questions as well. Yes.
You said you were gonna go over like if there's like a knife in their chest or like.
Oh, yeah, thank you for reminding me. So let's say this is our penetrating wound, right? So do you guys know what not to do?
Take it out.
Good job. So so you don't want to pull out an object if you see something stuck in the person's body, because that can cause further injury. You could have just stuck it in further. It can break off. So what you're gonna do, so I apologize. So what you're gonna do is you can take any type of equipment that you may have. A lot of times we use gauze, and I apologize that I didn't bring it. And you make it into like what we call a donut or soft. You can take a cup, like a plastic cup, and like a water bottle and cup, cut it. Anything that can protect that object, surround it with gauze, and try to make it so it's not going to be moved while you're moving your patient, because you don't want any other objects to hit it to cause further injury. So really that's what's covering, or that's me covering a penetrating wound with the object still in it. So you're still gonna do your life-saving interventions as best as you can. The main focus then is just to keep that object in place as best as you can, whether packing it with gauze all around it, putting like a plastic cup over it to ensure like it's not getting messed with at all. Any other questions? Who's gonna be my volunteer? Come up here and like walk us through this. There's a nice army mug in for you. For it. All right. Because you didn't want to take the MPA last week, right? I remember you.
Oh, good way to remember you.
And then after you, then if you guys want to take turns to go over this, you can. So you can open up another one too if you want. You don't have to use this one.
Okay, so just hold.
Sorry?
Am I like putting it this thing or just you said
No,
there was
go
a hole
over
in
like
it.
you
and
just
the
came
thing.
across the patient.
Oh.
You just came across the patient, you don't know what's going on.
Well,
Just like we would do with the elderly patient.
So first of all, he's decapitated. And it's kind of the biggest
Got bigger
problem.
problems than that.
Exactly. But in the event that like his head was still attached, check for hemorrhage, right? H. HB. A.
HABC.
Airway. Yeah, breathing airway. So check for the airway. Head's gone, so that's next problem. C.
No, B, you're at B. HABC.
HABC.
So if I didn't clarify, if I confused you guys, so you stop at each one. So you H, ensure that H is taken care of. Then you go to A, make sure A is taken care of, and then B. So you're on B, right? You're on breathing.
Yeah.
This covers your respirations
Gone.
in your chest.
So the pneumothorax, if he's not breathing, you can check for the trachea to be deviated, and that means that there's a pneumothorax there, so it's pushing everything to the side. That was what this one's for. Yeah. And so second intercostal, your little Hawaiian thing, and then middle finger to second intercostal, and then mid-axillary. Somewhere there.
Do you feel the ribs? Oh, you're going on the side?
Yeah.
Oh, okay. So between the fourth
Third.
and fifth.
Okay. There's a hole there.
Don't cheat. That's where they practice chest tubes.
So okay, fourth and fifth. Oh, I can feel it. Okay. So yeah, it's like there. You push it in. Or not.
Yeah, yeah. So. Okay. Yeah. Okay. And make sure you take this out.
Yeah, it's not going in first. Is that all it's supposed to go in? So there's a pot.
Because there's something in there. Like
Okay.
with the human, it would be different.
Okay.
My bad.
And
There's a
then-
battery pack in there.
Oh
Here.
shit, I forgot. Then remove the thingy, and then you should hear air, right? Air or blood coming out. And then he's saved. I'll be taking questions after.
You didn't cover the hole.
Nice, did I step a hole?
No,